Right now there's multiple ways that a patient can benefit. Just thinking about it simply is, right now we're already using telemedicine in many practices where we use telephone contact to educate patients, to triage them over the phone, to communicate back to them. Through interacting with electronic medical records or email communications between doctors and patients and between patients and extenders of physicians, that's already happening, and it would be very difficult to manage them without using those tools already. One area that it can be useful is teleconsultation with your provider. So for example, the patients that live a significant distance from the medical center, or even those that are close but don't want to take a half a day or a few hours off of work, they want to step aside and do a teleconsult, that can be a very viable strategy. There's some barriers to that. Some are licensing and how far you can extend your reach with a teleconsult. Right now a patient has to establish with you in the practice or has to be in the state with which you're licensed to be able to provide those services. I believe over 30 states allow you to bill for telemedicine services, but not all commercial insurances have those codes set up so that there's a way for you to bill for your time. Other areas where it may be useful are telemonitoring, and that's what we're doing, where we're using simply cell phones with texting to monitor our patients more closely. So we actually have a grant through AHRQ to evaluate whether standard care versus two forms of telemonitoring, or either weekly, or I should say two frequencies of telemonitoring, are more effective. So one is every other week and one is weekly. And so that's going to be a one-year trial with 3 centers, University of Maryland, Pittsburgh, and Vanderbilt, where we're looking to see if frequent monitoring of patients' symptoms and side effects, giving them education and medication prompts, will improve their outcomes over time. Right now, in the current study that we're doing, we're limiting it to patients with a flare of disease in the last 2 years, thinking that patients who have been in a more long-term remission will have, for their benefit, have less variability in the disease, less flares. So we're trying to target a group who's been active more recently, but there's some patients that may benefit more than others. So we talked about access to care, so the group that lives further from a referral center or a practice that has an interest in IBD. Another group is maybe focusing on patients who are initiating new drug therapy to look for side effects, so maybe a short-term burst of telemedicine. The most likely patient to be non-adherent to therapy is a young male single who's working. So your high-risk group patient there might be an example. Adolescents would be another one, although we're studying adults, but certainly telemedicine approaches have been applied in adolescents. And then we're also going to look at our group of patients that have been recently admitted to the hospital. Around 10 to 15% of patients will be readmitted within 30 days. So we think there may be an opportunity there, either through teleconsulting or telemonitoring, to interact with them more frequently in that first 30 days to try to stave off any problems and prevent readmission or repeat visits to the ER.